I think the subject today is having a lot of debate about the thrombophilia and the poor reproductive outcome. I hope we can find a conclusion. Yes, you can see my slides now?
Yes.
Okay. Okay, thrombophilia and poor reproductive outcome. Actually, the poor reproductive outcome as recurrent pregnancy loss, repeated implantation failure, and other pregnancy complications. A lot of debate about. Actually, during pregnancy, we can observe inhibition of anticoagulation and activation of procoagulants. As we see here, during pregnancy, there is a high venous pressure, decrease the natural anticoagulants, decrease the levels of antithrombin 3, protein C, and the protein S. Actually, if we see here in blue, protein C and protein S and antithrombin, if they are decreased more, we are going procoagulation, and this is what is happening in pregnancy. And if there is a thrombophilia, this will become more in this pathway. And also the other mutations like methyl tetrahydrophoric reductase, antithrombin deficiency, and the prothrombin, it will be in the way for coagulation. So thrombophilia is a term, the thrombophilia term is used to describe a blood coagulation disorder with increased risk of blood clot formation in vessels. Actually, it may be congenital thrombophilia or acquired thrombophilia, and all the symptoms depend on location as well as the extent of thrombosis. Thrombophilia was first introduced by Egeberg in 1965, and until now, it expresses any disorder related to anticoagulant mechanism causing increased tendency of venous thrombosis. Thrombophilia accounts for approximately 15% of women with recurrent pregnancy loss. We will start with recurrent pregnancy loss. The thrombophilia may be inherited like factor V and prothrombin mutation, hyperhomocysteinemia, protein C deficiency, protein S deficiency, activated protein C resistance, antithrombin deficiency, or acquired like the most famous is antiphospholipid syndrome, advancing age, malignancy, immobilization, trauma, pregnancy, estrogen use, and others. Actually, it is a long history of discovering the types of thrombophilia, and as we see that a lot of thrombophilia agents are discovered recently in the 90s, and so I think that the black box is still closed, and so we may discover in the next years a lot of that, and I usually tell my patients that not all secrets are still known in the recurrent pregnancy loss. This classification is very important all through our presentation because the high-risk thrombophilias, medium-risk thrombophilia, and low-risk thrombophilia is a classification that is important to judge our management and practice for thrombophilia. So please remember that the two antis are the high-risk thrombophilias, the antiphospholipid syndrome and the antithrombin deficiency. What do we mean by risk? And these numbers indicate the risk of incidence of first episode of venous thrombosis. If it is in the normal patient, the risk is 1. We have the risk multiplied by 4 with oral contraceptive pills, multiplied by 7 in factor V thrombophilia heterozygote patient, and it may reach 35 if we combine oral contraceptive pills with factor V, and even to 80 multiplication with factor V laden and homozygous factor. So the first question in recurrent pregnancy loss, should we screen for thrombophilia in recurrent pregnancy loss? We have a lot of guidelines. Actually, the National Society of Genetic Counselor guidelines suggested that testing just for thrombophilia, factor V, and prothrombin mutation for all patients with pregnancy loss is what we can do. While testing for protein C, protein S, and antithrombin deficiencies offered only in women with personal or family history of venous thromboembolism. And so this is the first step that we should concentrate, that we have to care for the family history and personal history. The family history of venous thromboembolism and the personal history is very important in deciding if we should care more to the thrombophilia or not. If you find a patient with the first group, with factor V and the prothrombin mutation, we should go for full thrombophilia screening offered for women, because if the woman was diagnosed with defective factor V or prothrombin mutation, previously there may be coexist of another defect dramatically increase the risk of venous thromboembolism and the pregnancy complication. So there may be a combination. And so if we find the positive, we should care for the others. Again, is screening the woman for inherited thrombophilia prior to pregnancy is necessary? The American College of Obstetrician and Gynecology did not recommend screening for history of recurrent pregnancy loss or placenta abruption. Why? Why they did not recommend? Because it is unclear whether anticoagulation treatment reduces the risk of recurrence. So they say that if you cannot reduce the risk of recurrence, there is no need to test. This is their opinion. There is an insufficient evidence to support screening of women with history also of IUGR or preeclampsia. What about the Royal College? The Royal College of Obstetricians and Gynecologists, however, recommended screening for inherited thrombophilia for women with second trimester miscarriage. And always we find that the Royal College concentrates on the second trimester miscarriage as an important criteria for testing and for management. Okay, let us go through the EFRE guidelines in 2017 about the guidelines for thrombophilia screening in recurrent pregnancy loss patients. This is the inheritance thrombophilia. The first one is factor V leading mutation. The factor V mutation renders the factor V resistant to cleavage by activated protein C. And acquired activated protein C resistance was associated with higher risk of recurrent pregnancy loss in the first trimester. Positive test, as seen in these guidelines, was not associated with improved outcome for the couples based on lack of the effect of treatment on pregnancy outcome. And so if you do the test, it doesn't outweigh the results you will gain from it. The very important when we are dealing with thrombophilia is seeing the incidence. So this is a criteria for the incidence of factor V. As we see here, it is different. In Europe and Canada, it's like 5%. It is so different than Europe, than Africa and Arab countries. And so it is different in the management, in the diagnosis. And so the guidelines should be adapted in your country. And so this is an important issue. The second type of inheritance thrombophilia is prothrombin mutation. It will cause raising in the plasma concentration of prothrombin. In a European study among older women for fetal loss more than 10 weeks, rather than embryonic loss, they found correlation between prothrombin mutation and recurrent pregnancy loss more than 10 weeks. And similar to factor V, the clinical utility was judged as minimal and no need. And so the harm of testing this thrombophilia outweighed the benefits. What about protein C, protein S, and antithrombin deficiency? Actually, protein C, protein S, and antithrombin deficiency is less common. And it is very important to notice that they are more strongly associated with venous thromboembolism rather than factor V and the prothrombin mutation. While there is no strong or significant association between deficiencies in these proteins and the recurrent pregnancy loss. And so when you find venous thromboembolism history, you should concentrate on those proteins and not in the recurrent pregnancy loss. This is very famous in Egypt and Arab countries for testing methyl tetrahydrofolic reductase. The MASFER gene mutation in MASFER gene polymorphism have historically, this is what is written in the EFRE guideline, it is an historical testing, has been historically classified as a hereditary thrombophilia factor. But the mutations are no longer considered for routine assessment of thromboembolic risk. An association between MASFER gene 677C and the recurrent pregnancy loss has been reported in some reviews, as we see here. But others didn't find evidence for an association, and by total, they considered it not so much associated. Okay, this is an important tip when to screen for hereditary thrombophilia. Actually, it is better to postpone screening for hereditary thrombophilia until 6 weeks after the pregnancy loss. Correct interpretation of the results and the diagnosis of hereditary thrombophilia is possible for mutation of factor V leading and prothrombin, but it can be problematic for antithrombin, protein C, and protein S, most notably in protein S. So it is better to postpone the testing for 6 weeks after pregnancy loss. So as a collection, it is recommended from the EFRE guidelines as regards thrombophilia screening in recurrent pregnancy loss patients. The recommendation was not to screen for hereditary thrombophilia, in women experiencing recurrent pregnancy loss. But if additional risk factors are present, like family member with hereditary thrombophilia or previous venous thromboembolism, so if you have family history, if you have hereditary thromboembolism family history or previous venous thromboembolism, screening can be considered. And so this is the guideline for the hereditary thrombophilia. As we see, this table is very important. We find a strong correlation. Here is the problem, and here are the mutation. We find here a strong correlation with factor V and the protein and the prothrombin mutation in venous thromboembolism patients. And we find weak association in recurrent pregnancy loss, first trimester, second or third trimester in factor V and protein and the prothrombin mutation, and maybe in protein S deficiency for the second and third trimester. Okay, what about the acquired thrombophilia? The most famous is antiphospholipid syndrome, that it is very effective and very risky for its action because it inhibits SCG release, block in vitro trophoblast migration and invasion, inhibit trophoblast cell adhesion, and activate complement. Actually, to diagnose antiphospholipid syndrome, we should have at least one lab and one clinical criteria. The clinical criteria, one of both of those two, thrombosis, venous, arterial, or microcirculation, or pregnancy morbidity, like 3 or more consecutive miscarriages less than 10 weeks, or one fetal death or more than 10 weeks, or one preterm birth or more, less than 34 weeks, with normal fetal morphology due to preeclampsia or placental insufficiency. What about the lab? The lab, we should find the presence of antiphospholipid syndrome with antiphospholipid antibodies, either lupus anticoagulant, it is positive or negative, or anticardiolipin IgG, IgM more than 40, on 2 separate occasions, at least 6 weeks apart, like the Royal College stated, or 12 weeks apart, like the SRM stated. The other very important agent, and maybe more specific, is beta-2 glycoprotein, but actually there is poor lab standardization. And so, in spite it is very specific or more specific, we should care for the lab standard of analysis. And so, as we mentioned, we should have time in between tests. It should be like 6 to 10 or to 12 weeks to get good standard. And so for thrombophilia screening, the EFRE guidelines recommendation is to screen for antiphospholipid syndrome in women experiencing recurrent pregnancy loss for 2 times. And this is a strong recommendation, as we see. What about the Royal College for the inherited thrombophilia? There is fair evidence from the Royal College guidelines that women with second trimester pregnancy loss should be screened for inherited thrombophilia, including factor V and the prothrombin gene mutation. For elevated hyperhomocysteinemia without thrombosis history, supplementation of vitamin B6 and B12 and folic acid, heparin anticoagulation for history of thrombosis should be taken. And so for the Royal College guidelines, they insist that second trimester pregnancy loss should be screened for inherited thrombophilia. This is unlike the EFRE guidelines. This table is very nice for collecting all the guidelines from different places, German guidelines, American guidelines, and British guidelines. Actually, please see here the agreement. The agreement in the first step that screening for antiphospholipid syndrome antibodies is agreed to be done for recurrent pregnancy loss in the German guidelines, in American guidelines, and in the British guidelines. And see also the treatment of antiphospholipid syndrome. It is a combined treatment with low dose aspirin, acetylsalicylic acid, and low molecular weight heparin in all of the types of guidelines. And you can see here the difference in the presence of second trimester screening, as we say, in the British guideline. If you have second trimester recurrent pregnancy loss, you should screen for thrombophilia as stated in the Royal College guideline. And you should use low molecular weight heparin for pregnancy losses from the second trimester. This is the British guidelines. Okay, let us go to the treatment, how we will treat the patient with thrombophilia. Therapeutic intervention for recurrent pregnancy loss and thrombophilia patient. Low molecular weight heparin, a recent systematic review reported no benefit for prevention of pregnancy loss in women with hereditary thrombophilia and prior late more than 10 weeks of pregnancy or recurrent early less than 10 weeks pregnancy. It is neither in early or late important. And also a Cochrane review on anticoagulant treatment for women with recurrent pregnancy loss with or without hereditary thrombophilia reported no significant effect of treatment, aspirin, low molecular weight heparin, or low molecular weight heparin plus aspirin. What about intravenous immunoglobulin? There are no studies, and for steroids, there are no studies. An important question, should we refer to hematologists in our treatment? Most general obstetrician and gynecologists today are familiar with common prothrombotic disorders, and they are capable of investigating and diagnosing common forms of thrombophilia. Specialists in recurrent miscarriage and high-risk pregnancies often have a skill to undertake the management of pregnant women with thrombophilia. But actually, if you find other problems in vascular, in other thrombophilia with venous thromboembolism, we can collaborate with rheumatologists and hematologists when needed. So again, we should have a very good risk assessment, care for those of high risk, the two antis as we mentioned before, the antiphospholipid syndrome and the antithrombin deficiency. Those are high risk patients. It will differ in management. And the medium risk patients are all the other types of thrombophilia, like protein C, protein S, homozygosity of factor V, homozygosity of prothrombin mutation, or combined heterozygosity of factor V and prothrombin mutation. What are the low risk? The low risk are those with heterozygous for factor V, don't care with, or heterozygous for prothrombin mutation alone. Don't care with those heterozygous. Both of them are low risk if they are present as one mutation. And so this is American College of Obstetrician and Gynecology practical guideline recommendation for pregnancies complicated with inherited thrombophilia. So if you have a low risk patient, those are the management. Low risk patient alone, low risk patient with family history, first degree relative of venous thromboembolism, low risk patient with a single previous episode of venous thromboembolism. And so here, the management is just surveillance without anticoagulant. Here we can use prophylactic anticoagulant if there is a single previous episode of venous thromboembolism. Those are the low risk patients. If we transmit to high risk patients, the management will be different. If it is high risk patients without previous venous thromboembolism, the management is prophylactic or intermediate dose, as we will see. The high risk thrombophilia with single episode, the management is prophylactic with intermediate dose or adjusted dose, means high dose. And if there is a high risk, so the management here, thrombophilia with 2 or more episodes of venous thromboembolism, or thrombophilia with 2 or more episodes of venous thromboembolism with recovery, receiving long-term anticoagulant therapy, the management will be with adjusted dose according to the body weight, as we will see. So this is a summary. We have very high risk group, like patients with mechanical heart valve, acute venous thromboembolism, severe residual recurrent thrombosis. So you should have here therapeutic dose. Patient with high risk assessment category, those patients should have high prophylactic. Those are the two antis, as we always say. It is antithrombin deficiency and the antiphospholipid syndrome. And we have a moderate risk patients with the other moderate thrombophilia testing. Other moderate thrombophilia testing, as we say, all other than the heterozygous 5 thrombin mutation, they are low risk. There is a good practice point. It is not just to give thromboprophylaxis. It is very important, regardless the risk of venous thromboembolism, that immobilization of women during pregnancy, labor, and puerperium should be minimized. And dehydration should be avoided. Low molecular weight in pregnancy, low molecular weight heparin in pregnancy doesn't cross the placenta, we all know. There is no risk of teratogenesis, low risk of allergic reaction, recurrence, or significant bleeding. Usually no need for monitoring and the less number of injections with low molecular weight heparin. And the good bioavailability, if we compare it with unfractionated heparin. The advantage of low molecular weight heparin over unfractionated heparin, there is no need, as we say, for laboratory monitoring. And very important is the longer plasma half-life time, and the lower incidence of thrombocytopenia, no risk of thrombocytopenia, and the low risk of osteoporosis and fracture. A very important note, if you give tenzaparin, it can be used once daily, while enoxaparin and deltaparin, you may need to give twice dose daily for the short half-life time. This is the dose, we all know it according to the body weight, because we have variable body weight women in Egypt, and so we should classify the patient according to the body weight. This is the low risk prophylaxis. The high risk prophylaxis, you should start with 40 twice daily or twice, yes, daily. And we may have from tenzaparin 4,500 units twice daily. And the treatment dose is 1 milligram per kilogram every 12 hours. We will give low molecular weight heparin or heparin plus aspirin. Actually, aspirin and heparin, the combination of aspirin and heparin is effective in women with inherited thrombophilia, and the combination of aspirin and heparin is effective in women with history of even severe preeclampsia, IGR, and apraxia placenta or fetal loss, although no controlled studies on the subject are currently available. This is a Cochrane review 2013. This is a very recent study about the safety and efficacy of enoxaparin, systematic review and meta-analysis published this year. Actually, the risk of bleeding, what is more risky? Actually, during enoxaparin treatment, the bleeding is the same as no treatment. Enoxaparin is equal to aspirin, and enoxaparin plus aspirin is equal to aspirin, so don't be afraid of bleeding. The relative risk of pregnancy loss decreased with enoxaparin, as we see here. So if you give enoxaparin, it is better than control. If you give enoxaparin, it is better than giving aspirin. And the best is enoxaparin plus aspirin. And so the best in your patient is enoxaparin plus aspirin. Our second question today about recurrent implantation failure, and thanks to Professor Hamid, he gave a lot in this lecture about, and for the part of thrombophilia, as we know, the live birth of the total fate of the human embryo is just 25%. There are a lot of preclinical losses in implantation failure, in early pregnancy loss, and clinical miscarriage. So some studies reported increased hereditary thrombophilia in recurrent implantation failure, higher rates of methyl-tetrahydrofolate reductase deficiency, factor 5, thrombin deficiency, and antithrombin 3 deficiency in recurrent implantation failure. Thromboprophylaxis with low molecular weight heparin from day of embryo transfer in a randomized controlled trials increase the IVF pregnancy rate, but this is not steady in the studies, and most of the systematic reviews show that it is not truly effective. Other reported that factor 5, methyl-tetrahydrofolate reductase, and autosomal gene mutation do not give a significant role in recurrent implantation failure. And so it remains to be determined whether thrombophilic conditions are a cause of recurrent implantation failure, and there is no solid base at all to give treatment, as we see here, for thrombophilia, neither to screen for recurrent implantation failure, nor to treat in recurrent implantation failure. This very nice, what we call traffic light recommendation started by HEFIA authority since 2 or 3 years, and then this year by British Fertility Society recommendations. As we see here by red, where there is no evidence that this intervention is recommended, no enough studies. This is for repeated implantation failure. So screening hysteroscopy is red, ERA is red, and those immunological investigation is red, and also the congenital thrombophilia screening for patients with recurrent implantation failure is red in this recommendation. So we should not use it for assessment of recurrent implantation failure patients. What about treatment? Can we give heparin for patients with recurrent implantation failure as a prophylaxis? Actually, again, this is a red area we should not use. There is no enough evidence or sufficient evidence that it is effective or safe to give heparin for this reason. What are contraindications for low molecular weight heparin? Low molecular weight heparin should be avoided or stopped in patients with active antenatal or postnatal bleeding, bleeding diathesis like von Willebrand disease or acquired coagulopathy, in thrombocytopenia if it is less than 75,000, in uncontrolled hypertension, and in recent acute strokes or renal or liver disease. For regional analgesia or anesthesia, it should be stopped within 12 hours before, and then started after 6 hours to 8 hours after the end of the operation. Our last part in today's presentation about a branch of questions in the thrombophilia, which is methyl tetrahydrofolate reductase mutation, actually, because in our country there is a lot of debate about it, and so we can summarize it as the following. As we see here, the methyl tetrahydrofolate reductase 5 and 10 methyl tetrahydrofolate is a specific gene produces an enzyme responsible for multi-step process that converts the amino acid homocysteine to another amino acid methionine. So as we see here, this is the MUSFAR gene, changing the 5,10 methyl tetrahydrofolate to 5 methyl tetrahydrofolate. And this participate to transfer the amino acid homocysteine to methionine. This methionine is beneficial, and specifically methyl tetrahydrofolate irreversibly reduces the 5,10 methyl tetrahydrofolate to 5 methyl tetrahydrofolate. 5 methyl tetrahydrofolate is ultimately converted to methionine to make proteins and other important compounds. And so this is the beneficial pathway. When we have a problem in this enzyme, there will be a problem in formation of methionine and accumulation of homocysteine. Actually, hyperhomocysteinemia will cause a lot of problem, because elevated homocysteine will cause inflammation and increasing the risk of clot formation and make a lot of complications. This is the theory, but actually what we see in literature is not in competence with that. There are two types of mutation, heterozygous, this mutation and this mutation. And if we have just C677 heterozygous, 40% loss of methylation occur. If we have homozygous, 70% of methylation occur. If we have the other type, we don't know yet what is the problem. And if we have it is in homozygous, 50 to 70%. Another important issue is that in some patients, we have to look for the father because if the father have also mutation, there may be more problem in the offsprings. So what about the guidelines? The importance of this mutation in infertile women remains controversial. Gene has been investigated for the past 20 years. However, the importance of these mutations remains controversial. This is the issue, the EFRE guidelines, and the American College of Practice guidelines say that screening with either MUSFAR mutation analysis or fasting homocysteine level is not recommended in women with recurrent pregnancy loss. And so it is very crucial. Some few reports, as mentioned by EFRE guidelines, mentioned the use of N-methylfolate, vitamin 6, B6, and B12 to reduce the homocysteine level, but the evidence is lacking. So as a conclusion, screening for antiphospholipid antibodies, including lupus anticoagulant, is recommended in cases with recurrent spontaneous abortion and or placenta-related complications of pregnancy. Antiphospholipid syndrome is a serious acquired thrombophilia and represents a clear indication for the administration of low-dose aspirin prior to conception, combined with prophylactic dose of low molecular weight heparin from the start of pregnancy. Based on the currently available studies, recurrent spontaneous abortion in women with maternal hereditary thrombophilia is not an indication for prophylactic administration of low molecular weight heparin in subsequent pregnancies and for pregnancy losses after 10 weeks of pregnancy. According to the current guidelines, the maternal risk for thromboembolic event determines whether non-drug-based venous thromboembolism prophylaxis is indicated with low molecular weight heparin or not. In addition to maternal disposition over venous thromboembolism factors such as immobilization, hospitalization, dehydration due to hyperemesis, assisted reduction, or overweight are also clinically relevant in the assessment of maternal risk and the decision whether venous thromboembolism prophylaxis is indicated. Based on the currently available data, there is insufficient evidence that women who have recurrent spontaneous abortion should undergo broad screening for hereditary thrombophilia. Again, based on the currently available data, there is insufficient evidence that women who have recurrent spontaneous abortion should undergo broad screening for hereditary thrombophilia. Interdisciplinary cooperation between specialists in obstetrics and gynecology, rheumatology, and hematology is important to ensure optimal management of patients. Thank you.